So session 5, despite it is so difficult, but it can be very easy if you know the tricks and if you know how to approach the case. Okay.
Okay.
Even from the very first minute, you can get the diagnosis if you know the approach. From the very first minute, you can know the diagnosis. Okay, so approach in this case is very important. And by the way, here in Zoom, I just give you a full picture of his retina. Okay, every findings are clear. You can see the hard disease, you can see the blood hemorrhages, you can see the laser therapy. Okay, by the way, you did not mention the laser therapy, but
Yes,
it's
yes,
okay.
very,
Here in
and
the session 5, it's very easy because the findings are just in front of your face. Even if you do not have to, you do not know how to perform ophthalmoscopic examination, already the findings are visible to you. But in the exam, this will not be the case. You will need to be familiar with ophthalmoscope. Okay, some people might have difficulty just opening the source of light. Some people might fail to adjust the lenses, especially if someone else before you came and entered the station. Sometimes they will play with the focus wheel. Focus will be adjusted to 7 or 6 or 4 when your focus is 0 actually. Some people just take the ophthalmoscope and directly go to look into the patient eye, okay, and they will not see anything. Okay, so you have to be aware of how to approach the case. If you know how to approach the case, you can know the findings, even the findings of ophthalmoscopic examination. You can know it without even examining the patient. Okay, you will have to just ask a few questions, then you will know which finding you are going to see in your ophthalmoscopic examination, even before you start examination. Okay, so how to approach this case? You'll start like usual. Okay, hello there. Okay, not good morning, not good evening. Okay, this station already it has got enough stress. Okay, enough confusion. Do not confuse yourself. Hello there, regardless of whether it is morning or afternoon or whatever. Okay, because if you say to the patient good morning, like what you did, he will tell you good afternoon, doctor. This will not be a good start, believe me. Okay, and the examiner will feel that you are a little bit unconfident and uncomfortable. And examiners, they do not like weak candidates. You have to enter the station. Okay, you have to take control. Okay, especially at the start of the station. The way you start your station will have huge impact in the examiner's judgment, overall judgment. Okay, so hello there, is it Mr. X? My name is Dr. Tahir, one of the medical doctors in the exam today or in the clinic today. Do not mention also the name of the clinic. No need to focus whether this is a gland clinic, this is an eye clinic. It's a clinic anyway, it's a clinic. Okay, so hello there, my name is Dr. Tahir, one of the medical doctors in the clinic today. Is it Mr. X? Yes. I would like to ask you a few questions related to your health. Do not mention, I want to take history. Want to take history is not understandable to patients. What do you mean by I want to take history? From where are you going to take the history? I would like to ask you a few questions regarding your health, and I may need to examine you at the same time if that's all right. He'll tell you, okay, doctor, sure. Okay. You did very nice in your opening question. You did not tell the patient that it came to my knowledge that you have vision problem. Please tell me more. No, you did very nice in keeping your open question wide open. Can you tell me what brought you into clinic today? Because as we have previously discussed, sometimes the complaint from outside will be different from the main complaint or main concern the patient want to start with. Okay, so you started very nicely with an open question. You kept your open question wide open. Please tell me what brought you into clinic today. He told you, doctor, I have got vision problem. Here you made a tiny mistake. Okay, you told him for how long has it been going over. This should not be the first question. Okay, because till now you do not know actually what vision problem he has. Okay, so the first question should be, what do you mean by vision problem? Sometimes the patient might tell you, I feel my vision is blurry. I cannot see far objects. I have problem reading. I have problem with near objects. I have problem with seeing colors. I have problem seeing at night or when the light is dim. So the first question should be, what do you mean by vision problem? He will tell you, doctor, I am seeing black dots in my field of vision. Whenever a patient tells you that he sees black dots in the exam, make sure that this is due to microbleeds inside his retina. And if he is diabetic, this is diabetic retinopathy, full stop. From the very first question, you got the diagnosis. Okay. Then after that, you can ask your question, for how long has it been going over? He will tell you for 3 months. Here, there is a very important question you should ask here. Before this 3 months, are you known to have any vision problem before? This question is very important because you will cut the station short. From the very first minute, you can get the diagnosis and you can get your findings. How you will do it? Okay, what do you mean by vision problem? I am seeing dots, doctor. For how long has it been going over? For the last 3 months, doctor. Before this 3 months, have you been known to have any vision problem before? Is it the first time you get this vision problem? He will tell you, no, doctor. Previously, I had problem with my vision and I went to the eye doctor, for instance. Okay, or he will tell you, no, I have no previous problem with my vision. Let us suppose that he told you, it is the first time I got problem with my vision, doctor. Okay, have you got any long-term medical problem at all, Mr. X? He will not lie to you. From our side, it's mentioned that the patient has got diabetes, right? So he will tell you, I have got diabetes, doctor. Okay, do you go for your annual eye checkup or not? Okay, this patient actually did laser therapy, so there is no way that he did not meet an ophthalmologist before, right? Who did the laser therapy? Of course, he went to an eye doctor. He did check his vision. He was diagnosed with a medical problem, which is diabetic retinopathy, and for that they did laser therapy. So, have you got any long-term medical problem, doctor? Yes, doctor. I have got problem with high blood sugar. I have got diabetes. Okay. Do you go regularly for your annual eye checkup? He will tell you, yes, doctor. What did they tell you at the last visit? He will tell you, yes, doctor. They mentioned that diabetes is starting to affect my vision. Okay. How far did it affect your vision? Any treatment needed so far? Any procedure you have done? Okay. And you can ask a very direct and frank question here, very useful question. Did you do any laser therapy for your eyes before? As simple as that. Because in station 5, you have the right to ask questions and you have the right to examine, right? It is not necessary that you should be expert in ophthalmoscopic examination. You do it the right way and to detect laser therapy. No, you can simply ask your patient from the very first questions. You can ask your patient a direct and simple question. He will tell you, yes, doctor, I did laser therapy for my eyes. So by the time he tell you I did laser therapy, you have got the full diagnosis, not only diabetic retinopathy, proliferative diabetic retinopathy. Okay, because the laser therapy is only done for proliferative diabetic retinopathy. Okay, then you can go back to analyze your main complaint. You mentioned that you are seeing dots, Mr. X. Any other problems at all you have noticed? Any recent change to your vision? Have you got any problem seeing far objects? Have you got any problem seeing near objects? Have you got any problem seeing at night or when the light is dim? Okay, have you got any problem seeing colors? So, color vision, night vision, far vision, and near vision. Color vision, night vision, far vision, and near vision. Okay, he will tell you, no, doctor, just I am seeing dots. Okay, and I have got also problem with seeing far objects. So go and analyze your complaint as usual. For how long? How did it start? Is it getting worse or getting better? Then you will come to the associated symptoms. Here, associated symptoms is only local symptoms, and you did very nice on this. You ask him about pain in the eye, redness, grittiness of the eye, okay, any trauma to the eye, whatever, any local symptoms. Here is the time to ask about it in the associated symptoms. Then he will go to the constitutional symptoms, which will be of no benefit in this case, diabetic retinopathy. He will not have any fever or weight loss or loss of appetite. It is not relevant. Then you will move to the systemic review. And in station 5, systemic review is not like in history. Okay, you have to be very targeted, and you did very nice in this way, Dr. Awadi, right? Yes. Uday, sorry. So in the systemic review, your focus will be to ask about symptoms related to complications of diabetes. Okay, we have got microvascular complications and macrovascular complications, right? So in the cardiopulmonary system, you'll ask about symptoms of ischemic heart disease, any history of chest pain before, okay? And you should ask also about symptoms of heart failure. In the gastroenterology, you should ask about symptoms, GI symptoms related to gastroparesis and autonomic dysfunction, okay? And then in the urinary symptom, you did very nice in asking about frothy urine, okay? Because frothy urine is associated with proteinuria, and proteinuria is associated with diabetic nephropathy. And usually, patients with diabetes, they do not come with only one complication, okay? If he has diabetic retinopathy, make sure that he might have diabetic nephropathy or diabetic neuropathy or ischemic heart disease or problems of medium-sized blood vessels in general previously. So you need to ask about symptoms of ischemic heart disease and heart failure, autonomic gastroparesis in the GI, frothy urine in the genitourinary system, or change in the urine amount and color. Okay, and by the way, this patient, he was my case in the exam, and when I asked about other complications of diabetes, he was found to have diabetic retinopathy, and for this he did renal transplant. Okay, it's okay if you do not ask about this in particular in the exam. Okay, and even if you ask to examine the patient abdomen, they will tell you skip, but you have to assess the diabetes complication. Okay, so after you finish your analysis in the systemic review, then go for the past medical history. At the start, we asked the patient about long-term medical problems. He mentioned diabetes, right? Ask any other medical problems at all, any like high blood pressure or high blood cholesterol level. Okay, ask about other medical problems. He will tell you, no, doctor, I have got only problem with high blood sugar. Okay, here you should ask 2 Ds, double D, okay, or DM. Ask about DM. Duration, for how long have you been diagnosed with diabetes? And you did nice, you ask about this, okay? He will tell you for the last 6 months, 6 years, for the instance, okay? Then the M is for medication, which medication you are taking. Do not waste your time and ask him which medication you are taking, because sometimes patient might have a lot of medications for hypertension, medications for hypercholesterolemia, medications for DM, medication for heart failure, medications for peripheral neuropathy. Here, the best way to ask about this is, have you got any medication list? Have you got any medication list? Can I see it? Okay, and do not tell the patient drug list, because the common street language, drug is for illicit drugs. Okay, he might tell you, do you think I'm an addict? Okay, so tell him, give me your medication list. So the first point is D and M, DM, okay, duration of diabetes and medication received. Then you come to follow-up and control, follow-up and control. Do you see your GB regularly for your blood sugar? Okay, then is your GB happy with your control? Then do you know your last 3 months sugar test? Okay, these are the 3 questions for follow-up and control. Follow-up and control. Follow-up, whether he's seen his GB or not. Okay, control, is your GB happy about your control, and what is your last hemoglobin A1C test? Okay, here if you forgot to ask about eye checkup at the start of the station, here you can ask. Okay, and do you go for your annual checkup with the eye doctor? Okay, so the first question is D and M, which is duration and mitigation. The second question is follow-up and control. Okay, then if he has got a problem with control, for the instance, he told you my GP doctor is not happy with my control, and my last hemoglobin A1C was 13, for the instance. Here you have got problem with control. You have to analyze why this patient has got problem with his diabetic control. Okay, you have to ask about three things. MED. Okay, compliance to medication. Okay, compliance to exercise, and compliance for diet. Okay, so do you take your medications regularly? Do you exercise regularly? And do you stick to your dietary advice regarding diabetes? Okay, medication, exercise, and diet. This patient actually has got good control for now, but previously his control was very bad. If you ask in the past, he will tell you previously I had a problem with my control, but now after diabetes has affected my kidney and affected my eye, okay, I'm really worried, and I'm started to be more cautious. I am taking control about my my diet, exercise, and medication. I appreciate this. I appreciate that now you are trying to do your best to control your diabetes. Let us say, for instance, patient tell you that, no, doctor, really, I do not take medications regularly. You have to explore more. Why do you do not take medication, Mr. X? Okay. Sometimes the problem might be related to forgetfulness. The patient will tell you, I forget to take it, doctor. It's a lot of medications. I forget to take it. So here you have to offer advice. You have to offer help. You can suggest, for instance, applications. Mr. X, there is a lot of applications in the web. You can download one application. It will remind you to take your medications on time. Okay. There's also devices which can help the patient to remember taking his medicine. Or else you can advise the patient to tell someone else from his family to help him and to remind him to take his medicines. Okay. Sorry, mute please. Mute all. So in case of compliance was related to forgetfulness, you have to offer help, which will be in the form of either devices, applications, or someone else to help the patient to remember to take his medicines. Sometimes poor compliance might be related to side effects. Doctor, this medications is giving me a lot of side effects. This insulin, before I lost my consciousness because of low blood sugar. So here you have to offer help regarding this. I will consult. I will speak to my consultant to see whether we need to adjust your insulin dose so that your blood sugar will be controlled and you will not develop any side effects. Okay. Otherwise, if the medicine side effect is inevitable, you can suggest alternative after discussion with your consultant. Okay. Then, apart from forgetfulness and problems with side effects, sometimes the patient might not know why he should take the medicine. Okay, the reason to take the medicine is not clear. Okay, so you have to explain why you need to take the medicine and what if not taken. Mr. X, I am really sorry to tell you that we need you to take this medication regularly, okay, because we need to control your blood sugar. If we cannot control your blood sugar, you might lose your eye and you might end up blind, and diabetes might danger your life. It will put you at risk of developing heart attack. It will put you at risk of developing stroke, and you might it might be life-threatening. So this is how to explore reason for poor compliance and how to offer help also. Okay, so imagine that, for instance, the patient told you have got a problem with my sugar control because I'm not taking the medicine because I forgot to take the medicine. If you do not offer help in this regard, your clinical judgment will be affected. Okay, you have to offer help. Okay, so we finished analysis, okay, and the past medical history. We cornered the surrogate in the past medical history so that he admitted that he is on regular follow-up. Okay, diabetes has affected his eye, and already he did laser therapy. We have got the diagnosis in our mind now. Okay, we finished the systemic review to explore if there is any association or any other complications. Okay, then we came to the past medical history. No other past medicals apart from the diabetes. We explored the diabetes. We started by DM, which is duration and medication, then control and follow-up. Okay, and then if any problem with control, check compliance for med. M for medication, E for exercise, and D for diet. If any problem with compliance to medication, try to explore forgetfulness, side effect. The patient is unsure about why he should take the medicine or what will happen if he do not take the medicine. Okay, so we solve problems related to compliance. Finish the PDF. This is the P and D finished. Okay, go for the F, which is the family history. You did nice in asking about the family history. Okay, then social history, smoking. If the patient is a smoker, you have to stop him smoking. And if you do not do this, your clinical judgment will be affected. Okay, ask about driving and stop driving and notify the DVLA. This is very important. This is a fatal mistake. By the way, I have wrote in the notes that you did not ask about driving, but at the last second, you did save your neck. Otherwise, you would have failed this station. Okay, so driving is very important. So if you attended previous sessions, okay, we have discussed that in session 5, usually you should start the examination early, okay? Because let us assume patient has got chest pain, okay? You cannot know the diagnosis unless you do the examination early. You will do the examination, you will get pleural effusion, or you will get consolidation, or you will get nothing except for desaturation. Then the diagnosis will be pulmonary embolism. So usually in session 5, you need to start examination immediately after you finish analysis of the complaint, past medical, constitutional symptom, and system involved. Immediately here, it is the time to start examination. But in ophthalmoscopic examination, we have, sorry, in cases of fundoscopic examination, we have exception. You have to complete all the history before you start ophthalmoscopic examination, okay? Because there is a possibility that you will do the ophthalmoscopic examination and get nothing. But if you finish your history completely and appropriately using this approach, you will have known the diagnosis before even you start examination. So after you finish all the history point we have discussed, then come to your examination. And we have mentioned that before. Sorry, mute, please. Mute all of you. I will mute. So in session 5, when you start the examination, as usual, you will start by having a look on the vital chart, and you did very nice on this point, Doctor. You ask about the vital chart, but usually in session 5, as we mentioned before, the vital chart will be written outside. So make sure to write the vital chart in your paper. Okay, as soon as you start the examination, grab your paper, have a look on the vital chart. You will find the high blood pressure. Put it in your mind, because if you do not tell the patient and you do not tell the examiner that we need to control this patient blood pressure, your clinical judgment will be affected also. Okay, so grab your paper, have a look on the vital chart. Okay, put it aside, and then start your examination. And as we have also mentioned before, start with the patient complaint. Start with the local examination. And in this case, the complaint is visual complaint. Okay, so you need to start by examining his eyes. So how you will start examining his eyes? The first step is to check his visual acuity, because if you do not check the visual acuity and then you went and checked for the visual field, okay, patient will tell you, no, doctor, I cannot see on my left side. I am blind. My left eye, it's completely blind. this will be examiner will have a very bad impression about you if you do visual field examination without assessing the visual acuity. So start by assessing the visual acuity. And how to do this? Ideally, you should ask about chart, okay, a Snelling chart, okay. If it is not available, and most of the time it is usually it will not be available, then you can do finger counting, okay. Ask the patient to close one eye. Can you see my fingers? Yes, doctor. How many fingers? Yes, doctor. Visual acuity is okay. Then you can move to examine the visual field. This patient has no he's completely blind on his left side, okay, but on the right side he's able to see your fingers, okay. So visual field is only for the right eye, okay. You cannot do a visual field examination on the left eye. So how you will examine the visual field, as we have previously discussed. I will just share my screen. We mentioned that you will need to sit at the same level of the patient. Are you able to see my screen now?
Yes, sir.
So you will need to sit at the level of the patient. Your eye should be exactly at the same level of the patient eye, okay? And then you will sit one arm length far from the patient, as you can see in the picture, okay? Then you will draw an imaginary line to make like 4 quadrants in the visual field. You will test each quadrant peripherally and proximally. Can you see my finger wiggling here? Yes, doctor. And here, move proximally, and then move to the lower quadrant, okay, and complete all 4 quadrants the same way. Your hand should be exactly, or your finger should be exactly in the middle between your eye and the patient eye, okay. So after examining the visual field, you will move to examine the light reflex. And here in this patient, you'll find that he has got cataract on the left side, and on the right side, the pupil. If you saw the picture, the pupil was asymmetrical. I will share the picture again. Can you see this picture?
Yes.
Yes. The pupil here is irregular because previously he did operation. And can you imagine this? Actually, these findings were the findings in my case. This patient has got a lens implanted in the anterior chamber of the eye between the cornea and the iris. Okay. With the exam stress, you will never be able to see this. Personally, I did not comment about this finding. Okay, but they wrote it for me in the feedback, and they deducted 3 marks only for this lens because I did not mention this lens. They deducted 3 marks out of my score. I got 25 out of 28. Okay, so in the left eye, you will find the eye is completely obscured by cataract. Okay, so do not attempt to examine visual field or examine ophthalmoscopic examination or even light reflex on this eye. You will just find the cataract, nothing to be done on this side. Okay, here you have to comment about the irregular shape of the pupil, the presence of the lens, which is implanted in the anterior chamber of the eye between the cornea and the iris. Okay, then go forward and do if I mean other patient, not this patient, you will do the next step should be the light reflex. Light reflex, in addition to swinging light test. Swinging light test. Okay, a swinging light test, you will shine the light from the right eye to the left eye to the right eye again. Okay, the normal response is usually whenever you shine the light in the pupil, it will constrict, right? Okay, sometimes when you shine the light back on the pupil, it will dilate instead of constriction. Okay, this is a sign called positive Marcus-Gunn pupillary sign. Positive Marcus-Gunn pupillary sign or afferent pupillary defect. Afferent pupillary defect. Okay, so afferent pupillary defect indicates optic atrophy. If you find positive Marcus-Gunn pupillary sign, make sure that when you do the ophthalmoscopic examination, you will find optic atrophy. Okay, imagine that your patient is young patient. Okay, he has got problem with night vision. Okay, he has got problem seeing when the light is dim, and he have got problem of pumping into objects by my side. The patient told you that I have got problem pumping into objects by my side. He's young, okay, and he have a problem with night vision. You did visual field examination. There is restriction of peripheral field of vision. What do you expect to see in ophthalmoscopy examination, doctor? Retinitis pigmentosa, right?
Yes.
Even before you start ophthalmoscopy examination, if the patient is young, okay, he have problem pumping into optics by his side. He have night vision problem, okay?
Family history.
And you examine the visual field, there is restriction of peripheral field of vision. You should expect to see the bony specules, the bony dark black specules of retinitis pigmentosa in the peripheral retina before even you start examining your examine the fundus, okay? If you have afferent pupillary defect, make sure that there is optic atrophy. You will know this even before you start your examination. So that's why I'm telling you that fundoscopy is very easy if you know the approach. By now, most of the common cases which appeared previously in PACES regarding fundoscopy, even before we shine our ophthalmoscope in the patient eye, we got the diagnosis. Our patient, we ask him, have you got any long-term medical problem? Yes. Diabetes. Have you do you go regularly for your eye checkup? Yes, doctor. What did they tell you? They told me that diabetes affected my eye. Any treatment received? Yes, doctor. They told me that I need a procedure which is laser therapy. I have done this procedure, doctor. So our diagnosis is proliferative diabetic retinopathy, and the patient already did laser therapy. I will expect to find this when I do the ophthalmoscopy examination. Okay. If the patient has got restriction in the peripheral field of vision, he is young, no diabetes, no hypertension, night vision problem, so I expect to find retinitis pigmentosa. Okay. When I start to examine his fundus, I will look for the periphery for the bony dark specules of retinitis pigmentosa. Okay. Imagine that we did the swingle light test, okay, and it was positive for afferent pupillary defect, positive Marcus Gum pupillary sign. Before I examine the fundus, I know this patient has got optic atrophy. Okay, so by this way, we know the diagnosis before even starting the examination. This will make you feel comfortable. Okay, you will be confident to do the examination, and your fundoscopic examination will be just a matter of show. Okay, and to make sure that the findings you expected are there. Got the point, doctor? So we will start our examination by having a look on the paper to check for the vital chart, then the local examination, which will start with the visual field. If there is restriction of peripheral field of vision, keep it in your pocket. Okay, then go forward and examine the light test and the afferent pupillary defect. I don't know if you can see my screen. I will show you the afferent pupillary defect or the swingle light test. This is the normal. Whenever you shine the light, both pupil will constrict, right? I will repeat again. Are you able to see my screen?
Yes, sir.
So now the light in the right eye, right? Focus on the reaction of the pupil whenever the light is shine on the pupil. See? Constrict. Constriction again. Okay. This is normal. But in afferent pupillary defect, see? Constriction, right? No constriction. Constrict. Dilation. Is it clear? I will repeat again. You expect whenever the light is on the pupil will constrict. If the pupil dilates, this is afferent pupillary defect. This is optic atrophy, okay? So I will repeat the video again. Dilate. The pupil dilated instead of constricted. Is it clear? So this is how to test for the swingle light test. What is the benefit? because if there is any optic atrophy, I would want to know this before starting my fundoscopic examination. Okay. Then after the light test, in case you have got diplopia from the start, here you need to do the eye movement because there may be cranial nerve abnormality. Okay. But if you have got diplopia, do not do the visual field examination, because in order to do the visual field examination, your field of vision must be identical to the patient field of vision to be able to compare. Okay, but already he has got the diplopia. His eyes are not in the primary field of vision. You will not be able to compare your visual field to the patient visual field. So if there is diplopia, do eye movement and do not do visual field. Then you will move to fundoscopic examination. And before you start fundoscopic examination, we have got steps to do. The first step is permission from the patient. Okay. Okay, Mr. X, I would like to examine the back of your eye with this machine, not with this ophthalmoscope, with this machine. Okay. And I will need to dim the light to be able to see clearly. So permission for examination and permission for to dim the room light. Okay. Then instruction. Please choose a spot on that wall. Keep looking at it, and I will need to come closer to you. Okay. Is it okay if I put my hand on your shoulder? We will tell you yes. You need, by the way, some tutors might tell you do not touch the patient, do not put your hand while performing ophthalmoscopic examination. But believe me, it will be very difficult if you do not put your hand. It will be very difficult to focus. Okay. You can just take permission from the patient by telling him that, is it okay if I put my hand on your shoulder? He will tell you yes. Then you can proceed with examination. So permission for examination, permission to dim the light, instruction for the patient to keep looking at the distance, because when the patient look at far object, the pupil will dilate. Okay, so it's really important to tell the patient to look, to choose a spot on the wall and keep looking at it. So how you will take the permission and give the instruction? Mr. X, I would like to examine the back of your eye with this machine. Okay, please choose a spot on that wall. Keep looking at it. I will need to come closer to you. Is it okay if I put my hand on your shoulder? He will tell you, yes, doctor, no problem. Okay, then after the permission and instruction, you need to do some adjustment for the ophthalmoscope, as we mentioned previously, especially if one of the candidates enters the session before you. Maybe you will find the light source open or closed. Maybe you will find the focus is not well adjusted. So you need to make sure first that to open the light source, and select appropriate intensity. Okay, the light source should be strong enough to be able to see clearly, but make sure that the light is not too strong, because if the light is too strong, it will reflect back from the retina. Okay, you will not be able to see clearly, especially the hard exudate, because it's yellow. Actually, it looks like glares. Okay, it looks like as if the light is reflecting back from the retina to your eye. So light should be good enough to be able to see, but not too strong, because it will reflect back from the retina. You will not be able to see. And one more thing, if the light is too strong, it will be uncomfortable for the patient. Okay, and if the patient is uncomfortable, you will not be able to do your examination appropriately. So the first step in adjustment is to open the light source and to choose appropriate intensity. Okay, how to open the light source? Ophthalmoscope has got a handle, okay, which is the part of the ophthalmoscope you grab with your hand. Okay, at the top of this handle there is a rotating cuff. Okay, this rotating cuff, you will use it to open the light source, and you will use it to adjust the intensity of the light, as you can see in this video.
Most ophthalmoscopes have a
Okay.
rotating cuff at the top
Are
of the
you able
handle,
to see?
which switches the light on. It can
Hello?
also be used to adjust the strength of the light.
Hello.
Yes, it is clear.
Okay. Okay. So you will use this rotating cuff first to open the light source and then to adjust the light also. If you can see here, when you push
Most ophthalmoscopes have a rotating cuff at the top of the handle which
when you
switches
push
the
the
light on.
rotating cuff to the right, the intensity will increase.
It can also be used to adjust the strength of the light.
Okay, so the light source, the light should not be too strong and should not be too weak. You should be able to see, but make sure that the light is not strong and it will not reflect back from the retina. Okay, so this is the first step in adjustment. The second step, actually, there is different apertures in the ophthalmoscope. Okay, as you can see in this screen, the light itself, when you open the light, it can be in a large circle or medium-sized circle or small circle. This small circle, usually you will use it only if the pupil is not dilated, so you did not do dilatation for, you did not apply any drops to dilate the pupil, okay? And you did not dim the light. So the pupil will be too small. You have to choose the small aperture, okay? Then if the patient, if you dim the light, okay, but there is no dilated drops used, you will use the medium size aperture, okay? Exam-wise, make sure that you use the large circle, the large aperture, okay? Because the before you go to the station, they will have already given the patient drops to dilate the pupil, okay? These drops will be effective for 2 hours. So don't worry. Throughout the exam, the pupil will be dilated, okay? And before you start examination, you will ask the examiner to dim the light. So the best aperture size in the large size, okay? Some ophthalmoscopes has got red-free filters and blue filters and so on. These for the these are not for the purpose of the exam, okay? The red-free filter is green light, okay? Usually we use it to examine the blood vessels in details, but for the exam purpose, because there is no time, you do not need to choose this filter. Just make sure that the aperture in the large circle and the filter in the normal filter. So the first adjustment is for opening the light and the intensity of the light. The second adjustment is for the aperture and the filter. The third adjustment is the most important adjustment, which is for adjusting the focus. Okay, how to adjust the focus if your eye vision or visual acuity. Sorry, please mute, please. So if your vision is normal, you have normal visual acuity, just put the focus on 0 and you are good to go. You are good to go, okay? If you have a problem with far vision, you cannot see far objects, okay? You are short-sighted, you need to put positive focus, more positive focus, okay? If you have problem seeing near objects, you have problem with reading, you use your eyeglass only for reading, then you need to put negative focus. Is this clear? If your problem is with far vision, positive focus. If your problem with near vision, negative focus. How to apply this in the ophthalmoscope? Positive focus, usually the numbers will be either black, yellow, or green. Black, yellow, or green. Most of the ophthalmoscopes, it will be green, okay? And the negative focus, usually it will be red. All ophthalmoscopes, the negative focus will be red, okay? How to move to the positive focus? By rotating the focus wheel clockwise, okay? Positive clockwise, negative anti-clockwise, okay? So make sure before you go to the exam, if you wear an eyeglass, okay, you have to know, is your problem is far vision or near vision, okay? If it is far vision, you will need to choose positive focus. If it is near vision, you will need to choose negative focus, okay? And try to know your focus before going to the exam. For me, my focus is positive 2. So whenever I take the ophthalmoscope, I will make it positive 2. and I'm good to go. Unless the patient has got problem also, or has got a refractive error, and later on we will know how to compensate for this. But generally, if your vision is normal, select 0. If your vision is not normal, you are wearing an eyeglass, make sure to know your focus before going to the exam. So this is how to select the
Plus
focus.
lenses are usually green, yellow, or
There is
black,
focus
and are
wheel.
dialed clockwise.
This
With
is
minus
clockwise.
lenses most often being
Black
red and dialed
numbers, positive
anti-clockwise.
focus.
This
For
is used to
people
bring the
with
various structures into
problems in
focus
the
whilst examining
far
them.
vision, and this is
It
anti-clockwise.
also compensates for the refractive
Okay,
error in
for
both
people
the
who has
patient
got
and the
problem with
examiner.
near vision. So is the focus clear now? Is the focus clear? How to adjust the focus?
Can you repeat again?
Okay. So the first thing to do is permission and instruction. Okay, then adjust your ophthalmoscope. Open the light source, select appropriate light intensity, select the large circle, large aperture. Okay, make sure that the filter is the normal filter, not the green or blue filter. Okay, then adjust your focus. Then if you are wearing an eyeglass, ideally better you remove the eyeglass. Some people might tell you do not remove your eyeglass, but if you do not remove your eyeglass, you will not be able to put the ophthalmoscope close to your eye. Ideally, the ophthalmoscope should be as close as possible to your eye. Okay, the upper part of the ophthalmoscope should touch the medial side of your nose and the lower side of the upper eyebrow. Okay, it has to be too close. If it is a little bit far, you will not be able to see appropriately. Okay, so if you use an eyeglass, better you remove it. Okay, and then proceed with the examination. What is the first step in examination is to check for the red reflex. Check for the red reflex. Okay, how to check for the red reflex? As you can see in the picture, okay, you will be standing 1 arm length away from the patient, okay, and around 15 degrees away from the midline, okay, to the temporal side, 15 degrees, okay. You will shine the light into the patient eye, okay, and you should look through the ophthalmoscope. What you will see this image, okay. The retina will reflect the eye back. You will see an orange color like this. This is normal bilaterally. Normal red reflex bilaterally. What does it signify? This is normal, and there is no any problem. Nothing is between your ophthalmoscope and the retina. Okay. If the red reflex, for instance, is negative, you cannot see this orange color. Okay, this means that there is problem, either cataract, okay, or intravitreous hemorrhage, for instance, or tumors, anything between the retina and the ophthalmoscope. This is negative red reflex in the left side. Okay, this is abnormal. Okay, what you should see is the orange color, which is the reflection of the retina. Okay, so after you finish the red reflex, red reflex is okay, then you can go and proceed to examine the retina. How you will go? You will just follow the red reflex. You saw the red reflex, right? You will follow the red reflex and get closer and closer and closer until you reach very close to the patient eye. Okay, you will be able to see the retina. Okay, you will land on one of the retinal vessels. Okay, you will not see the whole picture, not like in Zoom, they will give you the whole picture. No, what you will see is something like this. For instance, are you able to see the screen?
Yes, sir.
Okay, so you will find yourself landing on area which you do not know whether it is lateral to the optic disc, medial to the optic disc, above, below, you don't know. So what you will do in order to reach the optic disc, you will try to localize one artery. And here, by the way, if the patient has got any refractive error, despite you adjust the focus, you will not be able to see clearly. So make sure that if you do not see clear retinal vein, clear retinal artery, try to adjust the focus here. Okay, either you add some positive focus or some negative focus, okay, until you can see the artery very clearly. very clear and sharp. Okay. Now you will have corrected your focus and the patient focus. Okay. Then what you will do, you will follow any retinal artery. Okay. You will find a V shape when there is bifurcation in the artery. Can you see this one here? There is some small branch from the artery. Okay. This branch will make like a V shape or like an arrow. Okay. As you can see in the next picture here. Okay. By the branches of the retinal artery and the retinal vein, you will find some arrows, okay, or V shape. Use these arrows, okay, to point you towards the optic disc, okay. Suppose you find this V, move forward, forward. You will find another V, move, 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 another V, move, move. You will suddenly you will see something shiny, okay. Make sure that this is the optic disc. Now you arrive safely to the optic disc. What to see in the optic disc? Okay, the normal shape of the optic disc, usually the optic disc medially or to the nasal side, the border will not be clear and sharp compared to the lateral or temporal side. Is that clear? Is this clear, doctor? The normal shape of the optic disc.
Yes, doctor.
Medially or nasally, it will be blurry, not sharp, not well demarcated, not like the lateral side. Lateral side will be more glary, more shiny, more well demarcated. This is the normal shape of the optic disc. And then you will find all the vessels gathering together here, okay, as if they have a meeting here, okay, in the center of the optic disc. This is the area when all the retinal vessels, retinal artery, retinal veins, and so on, will enter the optic nerve. Okay, so this is the normal shape of the optic disc. Okay, here again, if you can see, the nasal side is blurry, right? Not like the temporal side. Is this clear? This is very important, by the way. I will tell you why. I just want you to recognize the normal shape of the optic disc. Are you able to see the difference between each side, nasal and temporal?
Yes, doctor. It's clear.
Yes. So if you can see, it is written optic nerve, right? And there is arrow. This side is the nasal side, okay, or the medial side, okay. The patient nose is behind this optic nerve, behind this word, okay. So this area is blurry, and the other side is shiny, well demarcated, okay. If you see the optic disc, even the nasal side is well demarcated and shiny, just like a moon, like a light, like a lamp. Now your diagnosis is optic atrophy. Optic atrophy, especially if you have got a positive Marcus Gunn pupillary sign. Okay, this is the first diagnosis we got here in our fundoscopic examination. Okay, so how you will know that there is optic atrophy? All the borders will be clear and sharp, and the optic disc will appear just like the moon. Okay, I will show you. This is also normal optic disc because on the nasal side it is blurry. You are able to see it, right? But if we go to the next picture, this is optic atrophy. Are you able to see it?
Yes, sir.
Even in the medial side is well demarcated, okay, and clear, and the optic disc itself is shiny, okay. Again, even the nasal side is well demarcated. Optic disc looks like a moon, and this is also the same. Round, well demarcated, sharp margins, and shiny optic disc. This is optic atrophy. So we go back again. Laterally, sorry, mute please. Laterally to the optic disc, there is some area which is a little bit hyperpigmented, okay, due to excess melanin deposition in the retinal epithelial cells. Okay, this area is called the macula, okay, and the center of the macula is called the fovea centralis. This is very important, okay, because if there is any maculopathy, okay, findings will be in this area, in this hyperpigmented area. Okay, we will come to this later on. For now, what I want you to know is the normal shape of the optic disc and the optic atrophy. Okay, what else in the optic atrophy we would want to look for? Imagine that patient has got, for the instance, hypertension, okay, or pseudotumor cerebri, idiopathic. Sorry, mute, please. Mute, please. So then you were able to see the blood vessels gathering, okay, toward the center of the optic disc, but you are not able to see the optic disc itself. The margins are not there. You are unable to see the optic disc. Okay, it is not that shiny moonlight color like. Okay, and there is some swelling. What is your diagnosis? This is papilledema. Papilledema. I will show you a picture here of papilledema. This is also optic atrophy because the margins are clear, sharp, well demarcated, and the optic disc is shining like a moon, like a lamp. Okay, but if you see this one, where is the margins? The well demarcated, sharp margins we know about the optic disc. They are not here, right? You can see the vessels gathered towards the center. Okay, so this is the area where the optic disc should be, but I cannot see the optic disc. Instead, I can see some swelling. Okay, the optic margins are not clear. There is a swelling, and there is also some hemorrhages, blood hemorrhages. Okay, so this is papilledema. Okay, here in this picture again, the vessels are gathered in the center. There's blood hemorrhage, but I cannot identify the margins of the optic disc. There is some swelling, so this is papilledema. Okay, so till now we have got two diagnoses. Okay, we landed on the retinal artery. We followed the V shape or arrow shape or the bifurcation of the retinal vasculatures, pointing to the optic disc. We reached the optic disc. Okay, we examined the optic disc. Either it is normal or we have optic atrophy and papilledema. Sorry. So by now we have got two diagnoses, two possible diagnoses, which you can find in the PACES. So if I ask you, what is the differential diagnosis for optic atrophy, doctor?
Any cause of long-standing optic neuritis.
Good, excellent. What else?
Vitamins deficiency, like B12 deficiency.
Okay, although this is not a common
Multiple
cause.
sclerosis.
Anything else?
Multiple sclerosis.
Multiple
Neuromyelitis
sclerosis
optica.
cause optic atrophy through neuritis. We already mentioned neuritis. So I will give you a very nice mnemonic to remember. Icing. The first I is ischemia. Okay, ischemia. Okay. Then the C, compressed nerve. Compression due to any cause. Okay. Then the N, neuritis, which is optic neuritis, which is usually associated with multiple sclerosis. So I, ischemia. C, compressed nerve. N, neuritis, which is optic neuritis. Then the second I is increased intracranial pressure. Increased intracranial pressure, whether it is related to hypertension, intracerebral bleed, or pseudotumor cerebri, or space-occupying lesion, or cerebral venous thrombosis. Anything which will increase the intracranial pressure can cause papilledema, and then later on papilledema might be complicated by optic atrophy, by the way. Okay, so increased intracranial pressure will cause papilledema, and it will cause also optic atrophy. So the first I is ischemia, then compressed nerve, then neuritis, which is optic neuritis. Okay. Then glaucoma, icing. Is this clear? This is differential for optic atrophy. Then differential for papilledema is anything increasing the intracranial pressure. Again, hypertension, idiopathic intracranial hypertension, space-occupying lesion, anything which will increase the pressure, in addition to inflammation, neuritis. Okay, neuritis again can cause papilledema, and then if it is chronic papilledema, it will result in secondary optic atrophy. Okay, so we finish the optic disc. We go out of the optic disc again by following the same blood vessels. Now looking for any abnormalities in the blood vessels. Sometimes we will find small dots, red dot. Okay, small red circle on the visual wall. This is microaneurysm. Okay, ballooning of the retinal vasculature. Okay, and other findings you might find in the area there's cross between artery and vein. Okay, the artery is as if it's causing compression over the vein, so the caliber of the vein will be narrowed before and after the artery. If you can see this picture here, this is normal crossing of artery and vein. The large caliber is the vein and the small caliber is the artery. Is it clear? Are you able to see the picture?
Yes,
Yes,
sir.
doctor.
So if you can see the caliber of the vein before and after, it is the same. Okay, but look at this picture. Okay, if you look at the vein, the caliber of the vein is a little bit narrow at the area when there is cross between the artery and the vein. This is called AV nicking. AV nicking or arteriovenous nicking or arteriovenous nipping. Okay, usually this is more common in hypertension compared to diabetes. And it's very bad sign because it's a sign of indicates increased cardiovascular risk, increased risk of developing myocardial infarction, stroke, and so on. So we came back from the optic disc through the blood vessel. We checked for arteriovenous nicking. Okay, we checked for dot aneurysm or microaneurysm. If you can see, this is small dots. في نقط صغيرة حمراء. These are microaneurysms. Okay, usually microaneurysms because at the area of ballooning in the arterial wall, the permeability of the blood vessels will increase. So exudate will filtrate into the extravascular area. Okay, and this will give you hard exudate in the retina, which is also called yellow exudate. If you see here, there is microaneurysms and there is also yellow exudate. There is something yellow, the same color of the optic disc. Are you able to see it?
Yes, doctor.
Yes.
Sorry. So this yellow color is the hard exudate or yellow exudate. The small right dots are the microaneurysms. Okay, so now we have what? Arteriovenous nicking, okay, microaneurysms and hard exudate or yellow exudate. Usually microaneurysm and yellow exudate happen together because aneurysm is associated with increased permeability of the vasculature, and then exudate will accumulate in the retina. These again are two microaneurysms here, okay, and there is a lot of yellow exudate. And if you notice here, around the area of exudate, there is hyperpigmentation, a little hyperpigmentation lateral to the optic disc. So this is maculopathy, by the way. Maculopathy. Maculopathy is the same findings of retinopathy, but affecting the macula. Okay. So we came back along the vessel. We checked for any arteriovenous nicking, any dots or microaneurysms, okay, any hard exudates, okay, then any blood hemorrhage. This is blood hemorrhage, area of bleeding, okay, more circular, but it is larger than the microaneurysm, okay. These are blood hemorrhages, okay. By the way, oh, sorry. Just go back. Yes, what I wanted to tell you that the difference between flame hemorrhage and blood hemorrhage is the shape. Blood hemorrhage will appear like this, circular or oval, and flame hemorrhage will appear like this one. Are you able to see this one? It's a little bit elongated and sharp. Okay, so this is flame hemorrhage, and this is blood hemorrhage. Again, here, these are blood hemorrhages, okay, above the optic disc, and this is flame hemorrhage, okay, below the optic disc. In this picture, we have got yellow exudate with the yellow arrow, blood hemorrhage, the blue arrow. Okay, these are tortuosity of the blood vessels usually happen with hypertension. It is not important, not that important. And the green arrow is pointing to microaneurysm. Okay, so blood hemorrhage, microaneurysm, yellow exudates. Okay, and tortuosity of the blood vessels. We can check here if there is any arteriovenous nicking, negative. Okay, here again, dot some blots, microaneurysm, some blots hemorrhage. And here a lot of flame hemorrhage, okay, near to the optic disc. And there is a lot of blots hemorrhages also, but I cannot see any hard exudate or soft exudate. Now we come to soft exudate or cotton wool exudate. Okay, the hard exudate, which is the yellow exudate, is filtration from the blood vessels. The cotton wool exudate or the soft exudate is caused by retinal ischemia rather than exudate. Okay, so in this picture, there is flame hemorrhage. Okay, there is blots, and there is cotton wool spot or soft exudate. Again, here a lot of soft exudate. It will be like whitish and fluffy, as if there's a piece of cotton, okay, in the retina. Okay. Okay, so we went to the optic disc. We identified optic atrophy and papilledema. We came along the blood vessels, arteriovenous nicking, dots, some blots, some flame hemorrhages, hard and soft exudates, yellow and white exudate. Okay, then what else to look for? You should have a look on the retina if there is any small tree of vasculature, capillaries, a lot of capillaries, a lot of small arteries, as if there is a tree here. This is what we call neovascularization, new vessel formation. This is neovascularization. Is this clear here? This one also neovascularization, but mild. Here, there is severe neovascularization. Is it clear? The difference between the normal retinal vasculature and the neovascularization, new vessel formation is clear. This is the new vessel formation. If we go back to the retinal vasculature, the normal, this is the normal retinal vessel. Are you able to see the difference? These here are normal retinal vessels. Okay, and this also. This is the normal retinal vessels. Okay, but if you go back, there is a lot of small capillaries, abnormal growth of new vessels, which we call neovascularization. This is neovascularization here. Okay, this one is mild, near to the optic disc, new vessel formation, and this is extensive neovascularization. And by the way, it is very important in the case if you find neovascularization to mention that this patient, instead of diabetic retinopathy, he has got proliferative diabetic retinopathy. The difference between retinopathy and proliferative retinopathy is the new vessel formation, neovascularization. Okay, and here it is for urgent referral to ophthalmologist for pan-retinal photocoagulation, laser therapy, pan-retinal photocoagulation. Yes, initially they will do some steroid injections. Okay, they might try sub injections called anti-retinal epithelial growth factor agents, anti-retinal epithelial growth factor agents like Avastin, something MAB. You don't need to memorize the name of the drugs, but the collective name for them is anti-retinal epithelial growth factor agents. Anti-retinal epithelial growth factor agents. These types of injections will inhibit the formation of new vessels. Together with steroid, it is the initial therapy for proliferative diabetic retinopathy. Later stage or severe disease, they will do pan-retinal photocoagulation, or laser therapy. If you can see the screen now, this is how the laser therapy looks like. It will be like small, round, circular, well-organized circles in the retina peripherally, or either it can be also in the center. It depends on where the blood vessels has formed, the new vascularization. Okay, but it's really important to differentiate this from retinitis pigmentosa, because sometimes with laser therapy you will find black color as if there is retinitis pigmentosa, but it's actually laser therapy. Okay, so this is laser therapy. This is here again laser therapy. It is well organized. Not necessarily all of them should be black. Okay, sometimes it will be like the same color of hard exudate or the same color of the optic disc. Okay, so this is laser therapy. Okay, already from the start you ask the patient, he told you, yes, I did laser therapy. When you come to have a look, if you find this shape, okay, this is proliferative diabetic retinopathy and the patient did laser therapy before. You got the full mark. Finding wise, you mentioned everything. Okay, this is again also laser therapy. Laser therapy again, peripherally. Yes, this is actually my case in the exam looks exactly like this picture. Okay, there is laser therapy peripherally, but some of them looks dark, black. Okay, even some of the blood vessels looked black. But when I came to ask the patient any previous operation, he told me, yes, doctor, I did operation. What kind of operation? He told me, I did operation for cataract. At this time, with exam stress, I forgot to ask him about laser therapy. Can you imagine? Despite before I go to the exam, I was well preparing to for this case, and I told myself, if I find ophthalmoscopic examination, I will ask the patient about laser therapy before I examine the patient. And I did ask about procedures and surgery. He told me, yes, I have done procedure before. What is the type of operation you have done? He told me for cataract. Okay, here you should ask another question. Any other procedure, any laser therapy? Okay, if the patient told you I have done other procedure, cataract for instance, don't get confused. Again, ask him, did you do any other procedure? Did you do laser therapy before? It is very important. Okay, he will tell you, yes, I did laser therapy. You will enter the retina. Okay, this black color cannot be for retinitis pigmentosa. He's not young. He's diabetes. He has got diabetes with complication. His diabetes is not controlled. Okay, he's on regular checkup with the eye doctor. He told him that diabetes affected your eye and you need an operation or procedure, and he did laser therapy. How on earth this black color is going to be retinitis pigmentosa? It is nonsense, right? So before you start the examination, already you got the finding and you got the diagnosis. So this is laser therapy. This is also laser therapy again. The difference is this is well organized, not like retinitis pigmentosa. It will be not rounded. First, it will not be rounded. It will be like a bony specule. Okay, scattered bony spicules, dark color, black color. Most of them are black, usually peripherally, and it is not well organized. These are well organized because someone put them there. Okay, not like retinitis pigmentosa. So diabetic retinopathy finished, optic atrophy, papilledema finished. Okay, hypertensive retinopathy, by the way, looks the same like diabetic retinopathy, except in diabetic retinopathy, exudates will be more. In hypertensive retinopathy, it will be more bloody. Okay, and you might find also papilledema. Okay, arteriovenous leaking is very common in hypertensive retinopathy, but hypertensive retinopathy is not common in the exam. Okay, usually it will be diabetic retinopathy. So imagine that you enter the session, you found young patient. He is not diabetic, not hypertensive. Okay, and he has got problem with his vision. So what do you mean problem with your vision? Doctor, whenever I am walking, I have problem bumping into object by my side. I cannot see the side of the bed or table. I bump into objects while walking. Okay, this means he have got problem with the peripheral field of vision. Sometimes he will tell you, I have got problem moving from one lane to another, doctor. When I am driving in the street, I have problem moving from one lane to another, because in order to move from one lane to another, he will have to have a look in the mirror or to turn his head to the right to look if there is any cars or no, then he will move. Okay, so if he has got peripheral field of vision affection, he will not be able to move from one lane to another. So he has got problem with his peripheral field of vision, and you confirm this by examining for visual field. He cannot see at the peripheries. So this patient has got retinitis pigmentosa. What to expect to see in the ophthalmoscopic examination? This one. Okay, you will find dark, bony spicules like, okay, it will be black in color, okay, scattered, especially throughout the peripheral retina, usually the peripheral retina. This seems to be extensive because it's affecting a little bit even the macula. There is bony spicules. But by the way, this picture is mainly showing the lateral retina, because if you can see the optic disc, it is there in the corner. Okay, there is no medial side of the retina shown in this picture. So mainly the dark black bony specule will be scattered through the peripheral retina, giving the patient problem with his peripheral field of vision. Okay, this is again retinitis pigmentosa. If you can see the difference, it is not the well-organized, round, small laser cerebus. Okay, are you able to see the difference clearly between laser cerebus and retinitis pigmentosa?
Yes.
Yes.
Yes. Yes.
This is again retinitis pigmentosa. Okay, dark black bony spicules scattered throughout the peripheral retina. The patient will have two problems: restriction of peripheral field of vision and problem with his night vision also. Okay, again retinitis pigmentosa, dark bony spicules, okay, scattered throughout the peripheral retina. Again, the same retinitis pigmentosa. Okay, so by now we got the diagnosis of optic atrophy, papilledema, diabetic retinopathy, hypertensive retinopathy, retinitis pigmentosa. Okay, last thing I would like to add, when we start doing the ophthalmoscopic examination, we started with the light reflex. We followed the pink color of the retina. We landed on one of the retinal vessels. We used the V shape to guide us toward the optic disc. And in the optic disc, we examined the optic disc for any evidence of optic atrophy or papilledema. Then we get out of the optic disc and went over the blood vessel to look for any arteriovenous nicking, dots or blots, hard or soft exudates. Okay. Then we had a look on the retina, especially peripherally, to look for any evidence of diabetic or hypertensive retinopathy, and to look for any evidence of bony spicules suggestive of retinitis pigmentosa or the small, round, organized dots of laser cerebri. Okay. The last thing to do, and you are done with the fundoscopy, is to ask the patient to look directly to the light source. As soon as he look into the light source, he will bring the macula into focus. Okay, even if you do not see the hyperpigmentation of the macula, okay, just ask the patient to look directly into the light source. He will bring the retina, the macula into focus. Okay, see if there is any glary things going on here. Okay, if there is hard exudates, okay, hard exudates when it affects the macula, when the patient look immediately into the light source, you will just feel as if the light is reflecting back. If you did not see any maculopathy before, you will think that the light source is just reflecting back from the retina. But actually, this might be exudate, hard exudate or yellow exudate. How to make sure that this is not the light reflecting back? Now you can reduce the intensity of the light. Reduce the intensity of the light. If the glare remains there, the same degree of glary yellow things are there, this is maculopathy. Maculopathy. And by the way, maculopathy is very severe regardless of the lesions. Okay, because this is the area which we use it to see. This is the most important area for vision. Okay, so this is how it looks like. If you can see, it is just like a reflection of light. Okay, and by the way, when you do the ophthalmoscopic examination, you will not see this picture. You'll just see, just like, are you able to see my screen now? Yeah, this is what are you going to see if you ask the patient to look into the retina. If you did not, into the light source, if you did not see maculopathy before, you will think that your light is reflecting back from the retina. Just reduce the intensity of the light, it will not change. So this is yellow exudate affecting the macula. The patient has got maculopathy, diabetic maculopathy. Okay. Here again, if you can see, there is area of hyperpigmentation lateral to the optic disc. Okay, this area is the macula. The center of it is the fovea, and there is yellow exudate affecting the lateral part of the macula. So this is diabetic maculopathy. Okay, how to know the lateral side of the retina? How to know if this is the lateral side of the retina or the medial side of the retina? If you can see the blood vessels, it will go like a curve. Okay, the center of this curve usually there is hyperpigmentation, which is the macula, as we have just mentioned. Okay, this area is the lateral side. Okay, the medial side is behind the optic disc. Is this clear? So this hyperpigmented area is lateral to the optic disc. It's called the macula. The center of it is the fovea. If there is any lesion here, regardless of what is the lesion, this is maculopathy, diabetic maculopathy, and definitely the patient will have problem with his vision because it is the most important area for vision. Okay, this is again maculopathy, and this is also mild degree of maculopathy. Here there is possible optic atrophy also, by the way. And here extensive yellow exudates scattered throughout the retina and affecting only the upper medial side of the macula. Okay, so there is maculopathy. So then imagine that a patient came to you with sudden painless loss of vision, and he has got risk for thrombosis or has got risk for atherosclerosis. Okay, this when you explain to the patient, you will tell him that you have got eye stroke. Eye stroke. What is eye stroke? It is central retinal artery occlusion. Central retinal artery occlusion. It is the main artery in the retina. It is the main artery for vision. It is the main artery for the eye. So if it is occluded, this is eye stroke. This is how to explain to the patient. What you will find in fundoscopy examination, the retina, because there is no blood supply, it will be pale. Not like the pink or orange color. It will be pale, okay? And if you look at the macula, the center of the macula, which is the fovea, you will find cherry red spot. This cherry red spot is pathognomic for central retinal artery occlusion. Are you able to see it now? It will be like, yeah, red spot at the center of the macula, cherry red spot. And if you see the other part of the retina, it is pale. So this is retinal artery occlusion, retinal artery occlusion. Again, pale retina, cherry red spot, which is retinal artery occlusion, which is known cause for sudden painless loss of vision. Again, pale retina, attenuated vasculature because the retina is pale. Okay, and there is cherry red spot in the fovea at the center of the macula. Again, the same thing. Okay, so this is the first cause for sudden painless loss of vision. There is another cause apart from retinal artery occlusion, retinal vein occlusion. Retinal vein occlusion usually it will be bloody. Okay, a lot of blood hemorrhage and flame hemorrhage throughout the retina. Okay, in a patient who has lost his vision acutely and there is no eye pain, usually young female. When you enter the retina, you will find this picture, a lot of hemorrhage. Okay, usually young female, usually unilateral. Okay, and painless loss of vision. Again, retinal vein occlusion. And by now we are done for today. So just to recap, you did the red reflex. Red reflex is negative. They could be cataract or intravitreal hemorrhage or tumor. Okay. If red reflex is normal, follow the red reflex. planned in the retina, you will find retinal vessel. Follow the retinal vessel. Whenever there is bifurcation, they will be V-shape. Follow this V-shape. It will guide you to the optic disc. The normal optic disc is blurry in the medial side and well demarcated and shiny on the lateral side. If all the margins are clear, well demarcated, and the optic disc is shiny like a moon, this is optic atrophy. If you can see the blood vessels gathered and heading toward the center of the optic disc, but you cannot identify the margins of the optic disc, and there is swelling, congestion, some blood hemorrhage, and the patient is hypertensive, this is most likely papilledema. Okay, so optic atrophy and papilledema. Then follow the vessel back, look for any arteriovenous nicking, dots, hemorrhage, blood hard or soft exudate, cotton wool exudate. This is diabetic retinopathy. Okay, then we mentioned also the laser therapy, retinitis pigmentosa, retinal artery occlusion, and retinal vein occlusion. Okay, so by now you finished the examination. We will just go back. I will take you back to our case approach. We finished the history, then we started the examination. We had a look on the vital chart. Then we did the local examination, which start with visual acuity, because you will never do visual field without acuity. You did the visual field, then you do the light reflex and the swingle light test. If you have any positive Marcus-Gumpy pair sign, you will find optic atrophy. Okay, if you have peripheral restriction, okay. Then after finishing the local examination, after the light test and fundoscopic examination, our examination is done. Just what is left is the general survey, and doctor, you did very nice in the general survey. You should examine the pulse for atrial fibrillation, examine the eye for anemia and jaundice like usual, but it's very important to check the carotids for bruit. Let us assume that you got bruit, carotid bruit. Okay, this signifies carotid artery stenosis. Usually, if there is carotid artery stenosis, the ophthalmoscopic findings of retinopathy, it will be asymmetrical. It will be more severe on the side of bruit. Okay, so you go down and examine the heart, or better you just do examine for pitting edema. Okay, ask the patient for any numbness or tingling, assess sensation. Okay, ask if he had got any history, a past medical history of kidney problem related to diabetes. Okay, then PDFs, as we have just mentioned, diabetes. Okay, ask about DM. D for duration, M for medication list. Okay, then follow up with the GP and with the eye doctor. Is your GP happy with your control? What is your last hemoglobin A1C? Then follow up and control is done. Then go forward, and if the control is bad, try to assess why the control is bad. How you will do this? MED, compliance to medication, exercise, and diet. Do you regularly take your medications? Do you stick to exercise? Do you stick to dietary advice regarding diabetes? Problem with compliance. What is the reason why he's not compliant to his medication? Is he forgetting to take his medicine? Offer solution. Is he having problem with side effect? Offer solution. Does he maybe he does not know why he should take the medicine? So you should tell him why we need to take the medicine and what might happen if he do not take his medicine. Okay. So then by this point, doctor, you did mention some jargons to your patient. You mentioned a slit lamp examination. You mentioned optic nerve. Okay. You mentioned retinopathy. No need for this. You can just mention that diabetes is having a toxic effect on the eyes. Okay, affected your eye. It might affected your vision. Okay, Try not to mention jargon, okay? But it is really very important to mention to the patient that we need to refer you urgently to the eye doctor to have you checked, okay? Then we need to involve the gland doctor to optimize your blood sugar control. And you did mention this, by the way. Okay, then you stop driving, stop smoking, moderate alcohol. If he forget to take his medicine, tell him you can download application, or you can offer your device, or tell someone to remind you to take the medicine, because it's really important to optimize your blood sugar control. Otherwise, you might lose your vision and so on. Regarding occupational therapist, by the way, I know one candidate, he went to the exam. Okay, the patient had a treatable condition. Okay, then he mentioned, do you have any problem with your work? He said, I took sick leave for 3 days. He told the patient, we will refer you to the occupational therapist and so on. The examiner was very angry. Do you know the role of the occupational therapist? So I will just take a sip of water. So occupational therapist or occupational department, usually for chronic diseases with disability, like weakness, paralysis, or problem with the hand dexterity. Their main role is to keep the patient independent and to lead independent life. Okay, in your case, the visual acuity is still okay, and he has no problem with paralysis, and he has no restriction of his daily activities. So I do not think it is really important to mention the occupational therapist at this stage. Okay, but you should stop driving, moderate alcohol, stop smoking, offer help regarding compliance if the patient forget to take his medicine. Okay, and that's it. So when the examiner asks you about the diagnosis, do not tell him this patient has got diabetes or this patient has got diabetic retinopathy. No, already the patient told you that I did laser therapy. So confidently tell the examiner that this patient has got proliferative diabetic retinopathy and there's evidence of laser therapy. He did laser therapy before. Okay. By this way, you will appear more confident and more professional. But also, don't try to mention the small, tiny details. Don't mention to the patient, to the examiner, that this patient has got blots and dots hemorrhage, and he has got flame hemorrhage in the upper lateral retina, and he has got neovisual formation in the medial side of the optic disc. No, don't do this. Because even the examiner himself, he is not expert in ophthalmoscopic examination, okay? And in the exam setting, you will never be able to know exactly what are the findings. You will have, you will look into the retina, you will find something wrong is going there. There is a lot of blots and dots and exudates, but you will not be sure, is this a microaneurysm or bleed? Is this blood hemorrhage or flame hemorrhage? Is this hard exudate or yellow exudate? So these findings are not necessary, by the way. You just have to mention to the examiner that this patient has got diabetic retinopathy. The type of diabetic retinopathy is proliferative retinopathy because he did laser therapy. This is far more than enough. And the examiner himself, he will not need more than this. Okay. So the next question will be, how are you going to manage this patient? Usually, discussion will be around diabetic control to control his blood pressure. By the way, they gave you high blood pressure, 150 over 100. If you do not mention control of blood pressure, your clinical judgment will be devastated. You will lose a lot of marks. Okay, so discussion will be around referring the patient for ophthalmologist, referring the patient for endocrinologist, okay, to optimize his blood pressure control, tight glycemic control, okay, and to offer solution regarding any problems with compliance or so. And then do not mention to cover your clinical judgment, which is driving, smoking, you have to stop. Okay, and that's it. By now, I think we have covered everything. Hope I was able to clarify any confusion regarding fundoscopy or the way you should approach your case. Is that clear?
Jazakallah khair, sir.
Really amazing session. Thank you very much, Doctor.
Sure. Thank you for that, for attending the session.
Excuse me, Doctor. I have a question, not
yes,
regarding
please.
this case.
Yeah.
Just I want to clarify the thing.
Yeah.
Central scotoma and a large blind spot. Is it important in PACES or anything? you can
Central
teach?
scotoma, no. Never try to search for central scotoma, because how you will examine for central scotoma? You will examine for a large blind spot. When you do visual field examination, you will examine the peripheral field of vision, and you will need to bring red hat pink, okay, to map
Yeah.
out the blind spot. This will take at least 2 minutes.
Yes.
In order to map out the central scotoma, it will at least take 2 minutes. You have no time for this. You have no time. Don't you ever try to examine for central scotoma. This is just a matter of losing your time. And anyway, you will have, for instance, positive Marcus Gun pupillary sign, or you will enter with the ophthalmoscope. You will find shiny optic disc, as we have just mentioned, and you can diagnose optic atrophy. So why you should waste your time? You will not be able to cover other points related to clinical judgment, history points. You need to assess the diabetic complications. You need to assess diabetic control. There is a lot to cover here. This is fatal. If you try to do the central scotoma, you will lose the case.
Okay, thank you.
Okay. Okay.
Doctor, can I ask you a question? In the start,
Yeah, sure.
just I missed
Please.
part of the conversation. So
Yeah.
the patient, his main problem is the cataract, or his main problem is the diabetic retinopathy, which is
No, his main problem, he will tell you that I have got a problem with my vision. What do you mean by problem with your vision? He will tell you, I am seeing dark spots, dark dots in my vision of visual field. So his main problem is micro bleeds in the retina related to diabetic retinopathy. You will tell him, yeah, because you missed the start of the session. And by the way, this is the most important area. Okay, as soon as you ask him, what do you mean by vision problem? The next question should be, is it the first time you have this problem with your vision? Have you been diagnosed with any vision problem before? Do you have any long-term medical condition at all? He will tell you, yes, I have got diabetes. It is mentioned in the scenario from outside. He cannot deny it. He cannot lie. He will tell you, yes, I have got diabetes. Okay, do you go for your annual checkup with the eye doctor regularly or not? He will tell you, yes, doctor, I went for my eye doctor before. What did he tell you in his last visit? He told me that diabetes started to affect my vision. And any treatment for that, any procedures? Did you do laser therapy before? He will tell you, yes, I did laser therapy, because he did it. He cannot lie. So from the very first minute in the station, you will know that this patient has got proliferative diabetic retinopathy. He did laser therapy, and you will find this in your fundoscopy, even if you do not know how to examine fundus.
Okay. And so in the management, I have to mention the urgency of referral. So I should refer him urgently, right?
Yeah. You have to mention this both to the examiner and to the patient. We need to refer you. We need to get you checked urgently by an eye doctor. We need to involve the gland doctor to optimize your diabetic control. We will need to control your blood pressure. Okay. Discussion will be around tight glycemic control the blood pressure and other risk factors, including even his lipid. Okay. Urgent referral to ophthalmologist and control the blood pressure. And you should cover your clinical judgment, which is smoking, stop smoking, driving. If you do not stop driving, you will fail the station. This is patient welfare, clinical judgment, everything will be affected.
And should we address the cataract issue, since we were able to find this in our examination?
Yeah, of course, you have to mention cataract, and not only cataract. For me, they wrote
the irregularity
the feedback.
In the
I spotted the irregularity of the pupil, by the way, and I asked the patient, because to my knowledge at that time, irregularity of the pupil means that the pupil was operated before. Whenever the ophthalmologist touch the pupil, it will never be the same as like before. It will be irregular. It will lose its circular shape. So I found the pupil is irregular, but I did not focus enough to detect the implanted lens. I asked the patient, did you do any operation before? He told me yes. What operation he did? He told me I did operation for cataract. At this time, I forgot to ask about laser therapy. Can you imagine? So don't forget, if the patient mentioned another procedure, don't forget, ask him again about laser therapy. Did you do laser therapy or not? Okay.
Okay.
So
Thank you so much.
yeah, findings were cataract on the left side. On the right side, pupil is irregular. There's implanted lens in the anterior chamber of the eye, and there is proliferative diabetic retinopathy, and the patient did laser therapy. I mentioned everything except the implanted lens. I missed this. I could not see it in the exam, but they wrote it in my feedback. The diagnosis was written at the top of the feedback that the patient has got proliferative diabetic retinopathy, did laser therapy. There is cataract on the left side, and there is implanted lens in the anterior chamber of the right eye. This is the shape of the lens here. It's really difficult to see the lens in the exam setting. But anyway, this is the shape of the lens. Maybe if you elevate the eyelid, you will be able to see the lens more clearly. So the positive findings were implanted lens in the anterior chamber of the right eye, irregular pupil, diabetic retinopathy, laser therapy, okay, and other diabetic complications. He had kidney problem. For that, he underwent kidney transplantation, by the way. And you have to suggest examining the kidney for tenderness, because maybe this patient has got graft rejection, his kidney is tender, and because his renal profile is shooting, he has deteriorated. His vision is started to deteriorate. They will not allow you to examine his abdomen, but you have to suggest this. I would like to examine his graft for any tenderness. They will tell you no need, skip, but they will give you the marks for examination. Okay, just few points I would like to add. Egyptians, by the way, are smart people. So previously in Al Hammady hospital, because they know that if the candidate is smart enough and well organized, he will ask the patient directly, do you have any long-term problems? Have you been checked by ophthalmologists before? Any previous laser therapy? And so on. And the case will be too easy. So what did they do? They brought a patient of retinitis pigmentosa. From outside, they wrote he is diabetic. Okay, but diabetic only for, I think, 2 years, and well-controlled diabetes. And diabetes has not resulted in any other complication. Just like a red herring distractor to let you think about diabetic retinopathy. But when you enter the station, it is very clear. The patient is young, okay? He has got problem with his peripheral vision, night vision, okay? And you will be able to see the bone specules also. So take care if you are going to appear in Egypt, especially Al Hammady Hospital. This case appeared 2017, Hammady Hospital in Egypt, second carousel. So my case, it was in Royal Hospital. If you are going to appear in Royal Hospital, take care. This patient, almost every day it is appearing, okay? And there is another patient with Cartagner syndrome with bronchiectasis, also every day appearing in Royal Hospital in Oman Center. So take care for these two cases.
Sir, regarding this, if we do this fundoscopy and we find laser therapy, whether we see any new vascularization or not, we should say that it is a laser therapy with the new vascularization.
I got your point, but it is not needed from you to go extensively. You are not ophthalmologist. You are attending internal medicine exam. So just spotting that this patient has got diabetes affected his eye, okay, and he needs urgent referral to ophthalmologist is enough. Here you are a safe doctor. You diagnose the patient and you refer him to the ophthalmologist. But you will never be able, even the examiner, okay, in the exam setting, he will not be able to see if there is any new vascularization after the laser therapy. It's very difficult. This is impossible. Okay.
I am somewhat confused. Excuse me. The patient complains that I have difficulty or there is blurring of vision in my eye after he has been operated, and you find that there is
yes, got your point.
Yeah,
got your point. I also, by the way, thought the same way. This patient his problem is supposed already corrected by the laser therapy. Why he is still complaining of dots? But anyway, this is an exam case. What they will do, they need you to diagnose the patient that he has diabetic retinopathy and he did laser therapy. They need from you to be able to examine his fundus and to look for these findings. Okay. The patient, if you ask him in real life, he will tell you already complaint is improved after the treatment. But in the exam, there has to be complaint. Got my point? Yeah.
Okay, if he say that I have that problem, then we will say that he need urgent referral because of the new.
Exactly. Anyway, yeah, even if he did laser therapy, you don't know. You are not ophthalmologist. Maybe something new happened. Already, diabetes affected his eye. Okay, you have to refer him for ophthalmologist for further assessment and treatment. From now, from this point further, it is for the ophthalmologist.
Yeah,
he will take it from here on. Okay, you are
it
not
mean,
to.
the still will be a short term. He may say that I am this problem from 3 days or 4 days. Maybe like this he will say, or I have this problem.
No. My exam case was 3 months. He mentioned it has been going over for the 3 months, getting worse for 3 months.
Okay, thank you.
Yeah.
Thank you very much. Thank you, doctor. Thank you very much.
Dr. Hussam, sorry to ask you this question.
Yes, please tell me.
You mentioned that if the patient has peripheral field affection, we cannot do visual field.
Visual field examination?
Yeah, visual field examination for the peripheral field. If the patient have peripheral field affection or diminution, we can do for all patients or like in case of acromegaly. The patient will say that I have been bumping into object. For that patient, we need to do to detect the bitemporal hemanopia. Am I right, Doctor?
No sound.
I cannot hear the voice. Where is Dr. Hussam?
There is some problem in connection, I think.
Hello, sorry, I've got a connection problem. Your question, Doctora. I did
I'm
not get
asking
your question.
that you thought that if the patient having peripheral field affection, we cannot do visual field for him.
No, I did not say this. If you have diplopia, you will not do the visual field because the idea of examining the visual field is to compare your visual field to the patient's visual field. You need to sit at the same level, okay? The distance between you should be divided exactly 50%, 50%. Your finger should be in the middle between the patient eye and your eye in order to be able to compare. But if the patient has got diplopia, he has got cranial nerve problem, his pupil will not be in the primary position, okay? One pupil will be up and the other will be down, for instance. His vision, his visual field, despite it might be normal, but it is not like yours. You cannot compare. So it is nonsense to go forward and examine the visual field when the patient has got diplopia or has got cranial nerve abnormality. Got my point?
Yeah. Okay, understandable.
Is this clear? Yeah.
Clear.
Yeah. But regarding even for the instance, if the patient is retinitis pigmentosa and he have got a problem pumping into object, have got a problem with his visual peripheral field of vision, you need to confirm this by examining the visual field, of course, definitely. Okay.
Actually, doctor, regarding regarding maculopathy, what is the main complaint of the patient in case of maculopathy?
Reduce visual acuity, because the macula is the most important area in the retina for vision. As soon as the macula is affected by any lesion, the patient may end up blind. Okay.
Okay.
Okay. Any other question?
Ma'am, Dr. Hussam, I was asking about bitemporal hemianopia. For that, we
Yeah.
need to do the visual field, no?
Yeah, of course. You need to do it here.
Thank you.
You're welcome. Bitemporal hemianopia, by the way, it is for pituitary macroadenoma in case the patient has got acromegaly, for instance. But in retinitis pigmentosa, usually you will have tunnel vision. Tunnel vision. Okay, is this clear?
It's clear.
Yeah. So, any other question? Hope everything is clear by now. Thank you, doctors, for attending the session. See you next session, inshallah. Goodbye.
Thank you,
Thank you,
Doctor.
Doctor.
Thank you.
Thank you very much.